Welcome to NU 623 Adult Healthcare Unit 2 Presentation 1 on dysrhythmias and valvular disorders. Please refer to your syllabus for the chapters of the text that you need to read for this unit. The presentation is not a substitute for reading that text. It's only going to provide you with highlights regarding the subject matter for the week. I'm going to highlight some of the dysrhythmias that you're going to see in your reading this week. There are atrial arrhythmias, ventricular arrhythmias, and heart blocks. One of the most common rhythms that you're going to see in clinic is atrial fibrillation. When you do an EKG tracing on these patients, sometimes you'll see that they're in a rapid ventricular response, and this causes there's a loss of an atrial kick. So this combined together decreases their cardiac output, and the symptoms you're going to see are hypotension, diaphoresis, dizziness, and syncope. There's also the component of left atrial blood stasis because of the decreased atrial kick, and this leads to clot formation and risk for ischemic strokes. So all these patients will be evaluated for anticoagulation using the CHADS-2 scoring method. You can find this in your book on page 503. If they have a 2 or greater on the scoring, they really need anticoagulation. For patients who have non-valvular AFib, including those being female and having vascular disease in the equation, there's also a CHADS-2 VASC score that can be used. Another atrial type of arrhythmia is a premature atrial contraction. These are really common, but they're benign. They're rarely symptomatic. They can be brought on by stimulants or obstructive lung disease or heart failure. Supraventricular tachycardia, also known as SVT, is an umbrella term for rapid arrhythmias that occur above the ventricles. They can be hard to distinguish from atrial tach, flutter, or paroxysmal SVT, which is a reentry arrhythmia. Ventricular arrhythmias, you're going to hopefully not see these in clinic, but they can be life-threatening. Ventricular tachycardia and ventricular fibrillation are both lethal arrhythmias that require ACLS treatment protocols. And our text in our course does not go into this. This is a course you would have to take later, an ACLS course. PVCs can occur. They're usually symptomatic. They are usually benign, but frequent ones can indicate coronary artery disease, hypoxemia, hypokalemia, hypomagnesemia, dig toxicity, ischemia, stress, or stimulants. I want you to pay attention to the rhythm strips that are in your book on pages 505 to 506, so you can look at all of these rhythms and read about their characteristics. The next section that you're going to see is in heart blocks, where we have 3 distinct kinds, and we'll go over those more in another slide. So the heart blocks that you may see on an EKG tracing include the first-degree heart block, which can be caused by medications that are slowing the AV conduction, could be caused by coronary artery disease, or again, digoxin toxicity. There are 2 types of second-degree blocks. There's a type 1 and a type 2. They both have distinguishing characteristics. Type 1 can be caused by an inferior MI, heart failure, or digoxin toxicity. Type 2 can be caused by an anterior MI, infections, valvular disease, or digoxin toxicity. And type 2 leads to type 3, the third degree. So we need to always jump on the type 2s and make sure they're getting treated. See pages 504 and 506 for the descriptions and the EKG tracings that go along with them. As you're working up the dysrhythmias, from your history and exam, you're going to have complaints of things like syncope or palpitations or fatigue, chest pain, confusion, and dyspnea. Of course, you're going to do a complete cardiovascular exam and a neuro exam because you're looking to rule out the differentials for this. For your diagnostic test, you start with an EKG, which can be done right in clinic. sometimes can give you immediate indication of what's going on. If your EKG is completely normal and you're still concerned, you can do a Holter monitor. There are also 24-hour monitors that can be done on an outpatient basis. An echocardiogram could be done to see if there's any valvular disorders or functional disorders of the heart. Electrical physiology studies can be done, but these are done by an electrophysiologist, which is a specialized cardiologist. You want to do a CBC, CMP, TSH, and free T4, and a PT-INR as well. These diagnostic tests can lead you to other reasons for symptoms, and you want to always rule everything out. We're going to focus on the management of atrial fibrillation in this presentation. You can read about management of the other disorders in your book. This is the one you're going to see the most in clinic, so I wanted to focus on it. There are pharmacological treatments, and then there are procedures that can be done to manage this. Now, your goals of treatment in AFib are to control the ventricular response. You need to get that rate slowed down. Try to convert them to sinus rhythm. This can happen spontaneously, and the patient can even go in and out of AFib. You can use medications, or you can do synchronized cardioversion, which obviously would need to be done in the hospital. You also want to prevent any adverse cardiovascular events because you have a high risk of ischemic stroke. Before any cardioversions are considered, you should get the patient a transesophageal echo to look for any clots and consider anticoagulation based on the results of that echo and the length of time the patient has been known to be in AFib. So anticoagulation is usually recommended for AFib that has been onset greater than 48 hours and sustained, or an undetermined time. So it's also based on the risk for thromboembolism, the stroke and bleed risks of the patient, the type of atrial fibrillation, whether it's valvular or non-valvular, renal function, and the patient's preferences. In valvular AFib, you're only going to be able to use warfarin, and that can take 5 days to become therapeutic. So typically these people are going to have to either be anticoagulated with IV heparin or a sub-Q enoxaparin, while their oral anticoagulation is overlapping. So both are going to be started right away, and then when they become therapeutic with an INR of about 2 to 3, then they can come off of the IV or the sub-Q anticoagulation. In non-valvular AFib, a patient can go on warfarin, or they can use one of the newer anticoagulant agents called the direct-acting oral anticoagulants. These are actually preferred by a lot of people because there's less hassle, they don't require the laboratory monitoring, and they don't require the strict dietary restrictions that warfarin does. One drawback to them is many of them don't have any kind of a reversal agent. Be sure that you read about AFib management in your book on pages 511 and 512, and see table 36.1 for the treatments for non-valvular afibrillation. If you need to, you go to cardiology referral, and they can perform a synchronized cardioversion. They can do a cardiac ablation if they're refractory to all these other treatments, and there's actually implanted devices that can be used as well, and you can read about that in the book. The other managements of the arrhythmias, I believe, start on page 512, so go ahead and look at those. Okay, so if you have a patient in clinic and you have a new onset atrial fibrillation, you might need to send them to the ER, especially if they're acutely symptomatic or they have a rapid ventricular rate, because they're going to need telemetry, monitoring, immediate transesophageal echo, and so forth. Cardiology will be consulted in the ER, and then they'll usually follow them after discharge. Cardiology can do diagnostic testing, including the electrophysiology testing. They can do the treatment procedures, or they can actually manage the antiarrhythmics. Follow-up for patients after initiation of antiarrhythmic, they should be seen at least 1 week after that. If you're titrating or changing antiarrhythmics, you need to consider checking an EKG at each visit that there's been a change. And if you're doing anticoagulation with warfarin, you want to follow up INR within 4 days after any initiation of warfarin or change in the dose. Patients on mechanical heart valves, they require anticoagulation bridge therapy whenever anticoagulant is held. Just keep that in mind. As you're assessing and documenting your murmurs, make sure you pay attention to some of the characteristics. They can be benign or pathologic. A diastolic murmur is always going to be pathologic. They are graded in their sound from a 1 to a 6, so the softest to the loudest. They can have a palpable thrill in grades 4 through 6. The timing of the sound in systole or diastole could last through the whole sound, or it could be early, mid, or late in the sound. The pitch can be medium or high. The point of maximal impulse will correlate to the associated valve. The quality can be blowing, harsh, or musical. And the configuration could be that the sound is constant or it increases or decreases. When you hear a murmur on exam, the clinical presentation may be that the patient is asymptomatic, or they may have dyspnea or orthopnea, fatigue, weakness, chest pain, syncope, or peripheral edema. So what you really need to do is do an EKG, and then you need to do an echo. The echo is needed to diagnose the abnormal heart valves, whether they're either stenotic, which means they have trouble opening, or they're regurgitant, which means they have trouble closing. There are 2 main valves that are going to cause most of the issues for you, and those are the aortic and the mitral valves. Your CBC you want to have done because those with profound anemia may have a murmur, and this is a correctable cause, and as soon as you get them transfused, the murmur disappears. So here are some of the causes for systolic and diastolic murmurs. As I said earlier, a diastolic murmur is always considered pathologic. You have a table in your book that will show the characteristics, the physical exam findings, and the diagnostic findings of each valvular disorder. So I want you to look at that. It's too much information to put on a slide. And again, the aortic and the mitral valves are usually the main issues. Murmurs can be managed medically or surgically depending on the etiology and the severity of the underlying condition. For example, if you have a valve that is stenotic or regurgitant and it's pretty severe, that may require surgical repair. You can treat medically with certain medications, and this is mainly for symptom control. Referrals can be made to cardiology for evaluation and follow-up. If you don't have a confirmed diagnosis or if you have poor symptom control, this is a good reason to refer to cardiology as well. Patients should be monitored for dysrhythmias because valve problems turn into electrical problems eventually. On your follow-up, you may need to do serial echocardiogram monitoring, and this can range from anywhere from 6 months to 5 years depending on the severity and the symptom set of each valvular disorder. So this is patient dependent. Here are the resources that were used to create this presentation, and again I want to direct you back to your chapters in your book that has a lot of good information, and if there are any additional resources in the course module, I encourage you to look at those as well.